the opportunity to listen to myself speak is not one that I'm excited about.
You don't have to. I
Yeah.
mean, I could just drop it.
Yeah.
Welcome to PsyDactic. I am your host, Dr. O'Leary, still a fourth-year psychiatry resident. I am recording this on the 3rd of February 2024, but it likely won't release for another week or so. This is a podcast about psychiatry and often also about neuroscience, but today I'm lucky to bring you a special guest, Dr. Jon Lindefjeld, who is a colleague of mine. One of his particular interests is HIV psychiatry. He developed this interest during medical school when he helped co-author a chapter in Springer Nature's HIV Psychiatry, a Practical Guide for Clinicians, which was then published in 2022. The chapter he co-authored dealt specifically with drug interactions and complications of antiretrovirals and psychotropic medications. And he also recently gave a grand rounds presentation to our program discussing HIV psychiatry in general, after which I invited him on the show. The interview was conducted on the 30th of January. Our discussion focuses on PrEP, which consists of medications that effectively prevent HIV infections in at-risk populations. But we also discuss the history of HIV and AIDS, disparities in treatment, and other areas of concern for psychiatrists. So without further ado, here's the interview.
Well, thank you for having me. I'm Jon Lindefjeld. I'm a psychiatry PGY4 based out of Walter Reed, and I'm here to talk about HIV prevention in psychiatry.
Awesome. And I'm Dr. O'Leary. We know each other. We work together. I'm just going to record here for everyone that we're speaking for ourselves here. We're not speaking for anyone else. We're not speaking for Walter Reed or the Department of Defense or our residency program. This is all for our own academic benefit. Tell me a little bit about how you got interested in this topic.
Of course. So I was lucky enough as a medical student to have a mentor who is very involved in the medication interactions between antiretrovirals and psychiatric medications, primarily in HIV treatment. And she was working on a textbook and needed a co-author for a book chapter. So I was eager to do something like that, especially as a capstone project as a medical student. So that's how I got introduced to the topic. And then I am going to be doing a consultation liaison fellowship next year, and HIV psychiatry is very much considered in that wheelhouse. So those two things together motivated me to investigate this topic.
Nice. HIV and psychiatry, I don't think people think of those two things together all the time. Like they think of HIV and they think of maybe infectious diseases or something like that. Immunology. What is psychiatry's role in treating people with HIV, living with HIV?
Right. So there are a few manifestations of HIV and AIDS itself that are neuropsychiatric in nature, and that can definitely prompt the involvement of a psychiatrist, especially if there are behavioral disturbances such as disinhibition. That's often when a psychiatrist might be called. Furthermore, there is a higher incidence of HIV in patients with mental illness, and then you also see the reverse as well, that patients with mental illness have higher rates of HIV. So there's that connection there. And then additionally, there are often a lot of questions if patients are on antiretrovirals and also taking psychiatric medications, so that often requires a psychiatry consultation. And then finally, I would say that there are a lot of psychosocial issues that come up if someone is diagnosed with HIV. So that can prompt a psychiatric assessment as well. And then I know that I said that was the last one, but I think crucially for our talk today, we are in the business of disease prevention as physicians, and there are many opportunities, regardless of specialty, to prevent the transmission of HIV. So I think being aware of how to do that as a psychiatrist is very useful, especially because we tend to have a better social history and awareness of our patients' behaviors outside of the office.
You talked a little bit about prevention of HIV and how that we might be able to contribute to that, especially because, well, we talk to people about behavior, right? But so what are the ways that like a psychiatrist could help with HIV prevention in particular?
So I think the most critical thing that a psychiatrist can do to prevent HIV is identify the risk behaviors that are associated with contracting HIV, and then pointing that person in the right direction to make sure that they can get the medications or the education that they need to prevent HIV transmission.
And how do you get that information? Do you get that information from everyone during your intake interviews, or is it something that you think maybe this person I need to go into a little more detail about things?
Right. So I think I would say that I'm getting better at taking a sexual history when doing an intake with the new patient. I don't necessarily do that with my follow-up patients, but I do think that this is an area that many physicians are uncomfortable in exploring, but sexual health is very important, especially when it comes to mental health and well-being. Circling back to the initial question, the concept of identifying who's eligible for pre-exposure prophylaxis, for example, for HIV prevention, like you're often tipped off based on the other symptoms or the characteristics that your patient may have. So I think more often than not, if I have a patient who identifies as a man who has sex with men, so MSM, I might be more likely to ask about pre-exposure prophylaxis or HIV risk. I think if I'm doing a chart review of a patient that I'm seeing for a follow-up and notice that they were recently treated for an STI, it might prompt me to ask them about condom use, for example, or their exposure risk. And then, of course, if we're treating patients with substance use issues, screening to see if they're using injectable drugs or something else, that is typically another reason to get involved.
I'm a little bit older than most of the other residents, and I kind of remember in the 1980s when people first started talking about HIV, and no one talked about HIV in the early 80s. They all just used the word AIDS because that's how it kind of first presented when they saw patients who had already advanced into having an immune deficiency syndrome. So the public was very scared, and there were no treatments, and a lot of people were dying. And then I remember Magic Johnson. He's like a retired basketball player. He was one of the most famous people who contracted HIV, and he did it through very sexually promiscuous behaviors. So he was open about that. And that was the first time that the public as a whole really started to pay attention to antiretroviral drugs, because he started taking them. And so it was something where, okay, there's this sports star now who's taking antiretroviral drugs, and maybe having HIV is not a death sentence immediately. So there was this huge, huge change in how people viewed not just HIV itself, but who can get HIV, and whether or not how bad HIV is, how it can be transmitted. It took a few decades. Do you have any idea how people kind of view HIV now when you talk to people?
My experience is somewhat anecdotal as far as the perception of HIV. There's definitely differences. So I think when I consider how people view HIV, I think you consider the people who are at risk for getting HIV, and then there are people who wouldn't consider themselves at risk but could be at risk, but consider themselves as outside of that risk group. And my perception is that there are different perceptions of risk when it comes to getting HIV. So I think, for example, there are different adherence rates to PrEP. And so I think that comes with the perception that this is something that's dangerous or something that's not dangerous, or making a risk benefit calculation in some ways.
Maybe
yeah.
we could start by talking about what is PrEP? How would you describe PrEP to one of your patients? Say they'd never heard of it before.
Right. So if I was meeting someone for the first time and I was explaining PrEP to them, I would say PrEP is a medication that you take every day that helps protect you from getting HIV if you don't have it already.
Who would you recommend PrEP for?
So I'm typically inclined to see what the CDC recommends when it comes to infectious disease, primarily because it's not my my main focus of practice. And so when it comes to who PrEP is recommended for, it's typically three categories. So the first would be, broad umbrella here is if you've had anal or vaginal sex in the past 6 months and you meet one of these criteria. So the first being having a sexual partner with HIV, next being not consistently using a condom, and then the third being having been diagnosed with a sexually transmitted disease in the past 6 months. So that's the way the CDC breaks it down based on sexual behavior. But then they also recommend it in cases where if you inject substances and are sharing a needle with somebody else or have an injection partner who has HIV.
You just described who would qualify for PrEP. If someone came to you and they said, I'm a little bit concerned, maybe they don't meet requirements for PrEP, but they say, I would like to take it. Do you think that's someone who would qualify for it?
The CDC recommends that anyone who requests PrEP should be considered for PrEP. I haven't come across a situation where somebody asked for it without having any risk factors at all. I have heard anecdotes of some physicians who may be at higher risk for exposure to blood, for example, whether that be through surgery or procedures, that may have considered using PrEP while they practice. But other than that, I think the CDC's line is if you are requesting it, you should consider it as a prescriber.
And if someone starts on PrEP, how long before they would be safe to continue whatever behaviors that they were participating in before? How long does it take to work, I guess, is sort of the thing. Can they just go ahead and just keep on doing everything the way they did before? Is it best to kind of wait for a few days, a few weeks?
That's a great question. This was broken down for me. You're right in wondering if PrEP takes a certain amount of time to become effective. And so the way the CDC reports it is that if you are planning to have receptive anal sex, you get maximum protection from HIV at about 7 days of daily use. So that's important because when patients start taking PrEP, they need to understand that they need to use barrier methods for HIV prevention while they are waiting for the PrEP to build up. But then also important to understand is that for injection drug use or receptive vaginal sex, that actually takes about 21 days. So it's not the same as receptive anal sex. And then there's no data for PrEP pill effectiveness for insertive anal sex or vaginal sex, but the risk is assumed to be lower in those cases.
Okay, so there seems to be some things we just don't quite know. To be super safe, you might wait 21 days, but in certain situations, a week could be sufficient. What if someone told you, well, I do things on the weekend, so I want to try to just take it Friday, and then Friday, Saturday, Sunday, and then come off of it. Is that an effective strategy?
There is a practice that is not approved called on-demand PrEP. And the way that's been studied is a 2-1-1 schedule. And essentially that means so 2 to 24 hours prior to having sex or anticipating having sex, you take 2 PrEP pills. And then 24 hours later, you take another pill. And then 24 hours after that, you take another pill. This was studied in gay and bisexual men in preventing HIV. And the way it's been explained to me is that in those studies, the 2-1-1 on-demand method was used quite frequently. So there was the question of, is the frequency of this use similar to daily use? So that's why it's not quite clear, and that's why it's not recommended by the CDC.
What is the difference between PrEP and PEP? Like if post-exposure prophylaxis, say someone had sexual intercourse, they find out the next day that the person they had intercourse with is HIV positive. Is that different? How does that different?
PEP is something that post-exposure prophylaxis is something that you would take if you were concerned that you were exposed to HIV. And so, as you mentioned, and it's for emergency situations, and it's not a substitute, I'd say, for PrEP. And it's not the right choice for people who may be frequently exposed to HIV. And it's definitely something that is considered in the first 72 hours, especially if you're concerned you're exposed to HIV. And so I would say that this is different when it comes to practice in the sense that in the system that I work in, this is something that is best dealt with in the emergency room because there's a workup per se when it comes to cases such as sexual assault, for example, that involves other social services and then other services as well. So typically these cases are best served in my hospital system in the emergency room.
So I'm trying to anticipate, maybe one of my patients is on PrEP. They have a friend. That friend engages in some behaviors that are high risk, finds out that they had sex with someone who is HIV positive. The person who's on PrEP decides to give that person their medication and say, hey, take this, because they don't want to go to the emergency room. They're kind of scared. Is PrEP the same medication as you would get, or is it different?
It's not the same as PrEP. So PrEP is either Truvada or Descovy, and then there is an injectable medication as well. But the post-exposure prophylaxis is a different combination.
I know people do share medications a lot too. It's just one of those things that happens. So maybe in the consent process, be like, if you do have friends also who are engaging in these behaviors, it's not sufficient to give this to them after an exposure. You should encourage them to go to the emergency room and get a workup and get the appropriate medications. As a psychiatrist, what are the specific considerations that you have if you have someone who comes to you on PrEP, or they're going to be, you recommend to them that they see like infectious disease and potentially get a prescription for PrEP? What are the considerations that you have, like the top things you're thinking about?
So the first thing that I would be thinking about is medication interactions. And typically the patient panel that I have does not take that many medications, and they're typically younger. So the medication interactions are not always a concern. But for my patients who are on mood stabilizers or antipsychotics, I definitely need to reference whether or not those medications are interacting. The next thing I would consider is adherence. So I think we know that in patients who are experiencing depression or low self-worth, there can be decreased adherence to medications, which of course increases the risk of being exposed or contracting HIV. In some cases, I would be considering behaviors such as high-risk behavior in mania, for example, or impulse disorders. And that always has me counseling patients on the importance of adherence as well. And then finally, if my patients are experiencing a lot of guilt or shame or anxiety about being worked up for PrEP or testing for PrEP, so for your awareness, there is a standard prescriptive workup and regular testing intervals that patients go through if they're taking PrEP. And if there's anxiety about being tested for HIV, for example, that could interfere with the adherence as well.
I was just thinking, and this really goes back to something we were talking about before, but I had a patient who was on PrEP when he came to me, and he was on PrEP because him and his spouse were in an open relationship. So they're geographically separated from each other. One was living in a different place. And so they had decided, we can see other people, we can have sex with other people. And so they both went on PrEP. And then they had a conversation and like, okay, we're going to become exclusive again. We're moving back into each, so we're going to not see other people. How long should they continue the PrEP? Do you have any idea?
So if the question is if they close the relationship and stop having sex outside of their relationship, I think once they've both been tested for HIV and confirmed negative, then they can stop taking the PrEP so long as they're both monogamous.
Really, the thing would be to still confirm that neither of them have HIV. Maybe we could talk a little bit about the history of like the development of some of these medications. Antiretrovirals now are used for far more than HIV. The medications that were developed for HIV helped to open up the door for all sorts of treatments that we have for non-HIV things. Hepatitis, even COVID, we have medications now that probably owe their existence to the research that went into developing medications to treat HIV. Can you give a brief history of once we found out that HIV existed, how long did it take before we had effective medications?
So the period of time that the I think that we're talking about is the 1980s through the 1990s is when we first saw the onset of AIDS. And so I think, like you mentioned, it was kind of vague in the sense that we didn't know what it was. It was uh, essentially cases of previously young, healthy homosexual men with Kaposi sarcoma or PCP pneumonia popping up, and that really was confusing to the community. AIDS first came onto the scene in 1981. It wasn't called AIDS at that time, but this is essentially an identified illness that was interfering with the immune system of previously young and healthy people, and that was manifesting with unusual diseases such as Kaposi sarcoma. And so this essentially led to commissions being set up by the CDC, for example, a task force. And it took several years to identify the different routes of transmission. First, it was blood transfusions and then perinatal transmission. They identified later that female patients of men who were HIV positive could get HIV as well. So there was some confusion in the beginning, definitely no treatments at that time. And it was only in like the later half of the 1980s where there was essentially public education on what HIV and what AIDS were. And of course, I learned this secondhand. There was quite the impact of how people with HIV and AIDS were treated, as you mentioned, was very poor. There was a lot of confusion and fear and stigma out there. Some people credit Princess Diana actually for taking some photos with patients with AIDS, shaking their hands without wearing gloves, and that really spoke to what they were trying to dispel when it comes to transmission. Antiretrovirals first came on the scene for HIV in 1996, so that's quite the time span. So 1981 to 1996, and I think you can't really mention that timeline without crediting the advocacy for further research and development of treatments. Many people will say that the disease was somewhat neglected because it didn't affect the communities with more power and influence. And so it really took a lot of protests to get the attention of decision makers to take initiative on this.
Specifically, having grown up during that time, I remember among the communities that I grew up in when I was younger, that people called it a punishment. They thought that HIV was created by God to punish people for sexual promiscuity, particularly men who have sex with men. I was taught this as a child, or I overheard these conversations among the adults around, and I won't ever forget them. And there were even, what do they call those? The Saturday morning or Friday afternoon shows on TV where they would pick some social issue and they would make a little drama about it. I remember one was about a kid who contracted HIV through a blood transfusion. And at one point, I guess he's using a knife at the counter. He cuts his finger, and the mom has to treat the cut. But it's this in the show, it was dramatized to such a big degree because there's the blood, right? There's the scary thing, and she just ran some water over it and did everything that a normal mom would do in that situation. But the music was ominous, and it was really, really something terrifying for people.
Right, and I that reminds me of when I was in medical school, we had a panel of individuals. I think only one of them was diagnosed with HIV, but she had gotten HIV through a blood transfusion, and it was kind of framed as I didn't deserve this the way that other people might have. I had a lot of conflicting feelings about that, mostly in the sense that it's disease is not something that people earn or deserve. So I think that framework and perception still persists.
Yeah, and I think especially with diseases that are associated with certain behaviors, people tend to blame the person, like, oh, if you had just not done that behavior, you wouldn't have that disease, so it's your fault that you have the disease. When in fact, like most of the time, the behaviors they're talking about are behaviors that are normal human behaviors that everyone participates in, right? And it's like telling people, oh, you just should never have sex with anyone because, which is not going to happen. that cognitive bias, I think it's called attribution bias or something like that,
Mm.
where if someone else is doing something and you you look at them as being morally wrong for doing something, or if they make a mistake, it's their fault. But if you make a mistake, you don't attribute it to yourself. You're just like, oh, well, I was feeling bad that day, or I just made a wrong decision. But when it's someone else, it's easier to attribute that to some flaw in their character. It was 1996, you said, when antiretrovirals first came on the scene.
Right. And I think there was, within a 2-year window, there was a significant decrease in AIDS-related deaths in the United States. So there was quite the profound impact. I think much with any development of new medications, and I wish I had more information on this, but there is an access issue and an equity issue as far as who is at risk and who gets the treatments. So any strain on the system as far as access to healthcare, access to testing, being able to afford medications, those patterns that we see today are exhibited when it comes to HIV care. Especially the adherence to PrEP, for example, is studied quite thoroughly in the 2010s, showing us that prescriptions of PrEP are more likely to be prescribed to white men who have sex with men compared to Black or Latino men who have sex with men, despite there being a disproportionate need in those communities. So those racial disparities existed then and continue to exist today.
Even with the availability of prevention methods, there's a huge political issue sometimes because people view this like, oh, it's your fault for doing it. They think that certain things that would prevent, like clean needles that would prevent transmission, is encouraging people, one, to do drugs, and we shouldn't be encouraging that behavior. Epidemiological studies show that interventions like that, for instance, like have a huge impact on the rates of transmission, not just of HIV, but any kind of bloodborne illness that can be transmitted with a needle. So there's a lot of barriers based on people's like moral values and the political influence in a particular place.
Absolutely.
HIV is still a global pandemic, right? That's
right.
Yeah. And it's been a global pandemic since, well, probably the late 70s. We just didn't know about it until, the early 80s. What are the disparities that exist now in terms of places where people have access to medications or prevention methods?
So a lot of this is wrapped around a few things. So the first is awareness of whether or not you have HIV. So I think, if I remember correctly, it's just above 50% of people globally with HIV don't know that they have HIV. And that number in the United States is around 1 in 7. And so I think that may illustrate a few things. It may illustrate access to care concerns or fears of social stigma of or just essentially fear of getting tested because there's concern that the test might be positive. Globally, I would say that the biggest global health initiative for HIV/AIDS is the U.S. President's Emergency Plan for AIDS Relief. That's also known as PEPFAR. And so this was brought up during the Bush administration, the second one, by second, I mean second Bush.
Well, the first one didn't have a
He
second.
didn't, right?
Yeah,
So
he wasn't reelected.
we're talking like 2000, 2001 time
Right.
frame.
Okay.
So this essentially was the biggest initiative for global health engagement in any specific disease by any country. It was the largest contribution that had ever been made. And so it didn't come without controversy. So there was definitely a lens that only programs who are promoting abstinence and monogamy should get funding. And so you can see a few reviews of PEPFAR and its effectiveness down the road, and people seem to conclude that the abstinence only promotion globally was not as effective as it would have been if it had been more holistic. There are stories of essentially generations or like an age group being wiped out in sub-Saharan Africa due to HIV/AIDS. I think typically people in their 40s, so individuals who have younger kids who are also the backbone of the economy, doing a lot of work, that age group essentially was most likely to die at that time from AIDS-related illness. I wish I had the population graph for you to show you the effect that this had on the population age brackets as the years progress. But that was essentially devastating for so many people, especially for children who were orphaned or left with one parent, and then also terrible for the economy. And that's not the focus, of course. The loss of life is what's devastating.
That has consequences, right?
Right. It has profound consequences.
Yeah.
Access to care continues to be an issue in the developing world, and so hopefully PEPFAR. I guess I should plant any flags, but it would be nice to know if PEPFAR is going to be extended so that that aid can continue to be provided. Otherwise, we might see unintended consequences to ending that program.
I don't want to generalize, just to say Africa and that just mean everyone in Africa, but as a continent, statistically, very young populations compared to places where we're having fewer children and we have an aging population. Most countries in Africa have a very young population. And I wonder if part of that demographic being the way it is had something to do with the HIV pandemic.
That's a great question. I think I would be in a speculative space to comment on that. I do think you're not wrong to highlight sub-Saharan Africa. My understanding is that almost 2/3 of people living with HIV are in sub-Saharan Africa globally. Each community is different and faces its unique challenges as far as access to testing, access to prevention, and access to antiretrovirals for treatment. But I'm not exactly sure how the age breakdown would have influenced the transmission.
Do you know anything about what maybe the United Nations has done? Because you talked about the presidents. I assume that's the United States, right?
Yeah.
What about the United Nations itself? It sounds like America has been a global leader on this.
That's definitely my bias, I'll say. But so there's a program for HIV/AIDS based out of the United Nations called UN AIDS that emerged in 1994. Their headquarters is in Geneva, if you're ever interested in visiting. I don't have a thorough understanding of the way they organize things, but the United Nations and the World Health Organization are critical in managing these disease burdens. So I'm hopeful that they are doing something incredible.
So kind of getting a little bit back to the role of a psychiatrist, treating individuals who are either at risk for HIV infection or who have HIV and are on antiretrovirals. You've discussed that we need to make sure that we're constantly checking on medication interactions in the most updated databases that we can find, and then also treating certain conditions because the conditions themselves might contribute to, for example, lack of adherence to medication regimens that could worsen a person's condition. I've seen signs and I've heard U equals U. What does that mean exactly?
So U equals U is essentially a campaign that's meant to communicate that, so it stands for undetectable is untransmittable. The evidence behind that is if your HIV viral load is undetectable on laboratory testing due to taking antiretrovirals, that means that it's virtually impossible for you to transmit the disease. And so this is meant to destigmatize the illness and decrease fear around individuals who are living with HIV.
So if you are considering a relationship with someone who is HIV positive, who has been taking HIV medications and is regularly getting tested and has been undetectable consistently, then you are in a very low risk group of contracting HIV, even though you're in a relationship with someone who's HIV positive.
Right. So I think in those cases, they still recommend that the HIV negative partner continues to take PrEP. But the CDC does annotate that if you don't know your partner's viral load or they have a high viral load, then that's definitely a case where you would take PrEP. And then I think there's some shared decision making that goes on if your partner is undetectable.
Yeah, absolutely. I imagine, if you're having sex with someone who is undetectable and you're on PrEP, you probably have almost no chance of contracting HIV.
Right.
You are going into a consult liaison fellowship after this. And you mentioned earlier that the consult liaison psychiatry is often considered the subspecialty of psychiatry that deals the most with questions about PrEP or antiretroviral medications, or just how to treat patients who are HIV positive in general for psychiatric comorbidities. Why do you think the PCLS service is the one that took on that mantle?
I would be speculating here as to why consult psychiatry oversees the subdiscipline of HIV psychiatry. My understanding is that there is so much intersection between different organ systems, medications, and neuropsychiatric presentations of AIDS that initially these cases were probably brought to consult psychiatrists in the hospital setting. And that's probably where the case reports and the expertise was fostered, and then it became a subdiscipline of the consult setting. That would be my guess.
So it sounds like potentially it was just a historical accident in a way. The fact that so many people living with HIV were developing AIDS or other manifestations and were in the hospital for various reasons. And that's where the consult liaison service does most of its work. So they just sort of adopted that patient population early on.
Just made history.
Right. I was glad that you brought this topic up because I'm going into child and adolescent psychiatry as a fellowship. And I know that the young people nowadays, compared to my generation, are much more savvy about sex, sexually transmitted diseases or infections, HIV itself. And I want to be able to give them like the most up-to-date advice on, what are best practices if they're going to be sexually active, and what puts them at risk versus what doesn't, and what they can do to protect themselves and prevent at least, HIV. Antiretroviral medication doesn't prevent other sexually transmitted infections necessarily. So I think it would be very helpful for me to review this subject pretty regularly.
Definitely. And I think that raises an important distinction. You mentioned that PrEP doesn't prevent the transmission of other sexually transmitted infections. And I'm exposed to a lot of, I don't know how to put this. I'm exposed to some media memes, for example, about essentially gay culture. And there's this perception that now that PrEP is on the scene, that it's taboo to use barrier protection or to use condoms. And I think it's important to understand that the purpose of wearing a condom is not to exclusively prevent HIV. I think there's this idea that, there are very limited consequences to contracting any other sexually transmitted infection because I can treat those with antibiotics, for example. But we do know that there's treatment-resistant gonorrhea, and there are consequences to developing syphilis or chlamydia as well. So I think it's important to just know that people seem to think that condoms are a bit gauche, and that motivational interviewing, if you will, to wearing them is important, especially in people who are new to having sexual experiences.
Younger people tend, in general, to not have the same fears as older folks. They're more afraid of some things because they have less experience, but also with less experience, they're not necessarily have the level of consideration that they need to have for some of the behaviors they engage in. I think that's a nice way to put it.
Mm-hmm.
So educating them in a very matter-of-fact way, hopefully it's helpful. So you mentioned there has been changes in the culture, especially like of young gay men. As the different generations of young gay men have grown up, I can imagine being a young gay man in like 1992 and seeing a generation of gay men who are now in their more in their middle age, their 30s or 40s, and so many of them who either had AIDS or had friends and lovers who died of AIDS, and it just sort of decimated a whole generation of people. And then, being and not having any options other than potentially like wearing condoms. And now there are options. And so people are calculating their own risk differently.
Is there a question?
No, I'm just talking.
No, you're absolutely right, and I think one thing I'm so there is a new long-acting injectable for PrEP, and that's something that I think we're quite familiar with in psychiatry, but I'm not so sure if other disciplines are as comfortable with long-acting injectable medications. And so I'm curious to see if we see healthcare models that do a one-stop shop, if you will, where they have you get your STI testing, you get your screening labs done, you get your injection, you meet with your provider, and then you follow up again in 2 months. I'd like to see the adherence results from that.
Yeah, that sounds far too efficient to ever be real. Are there any other issues surrounding HIV that we haven't like discussed yet that you wanted to talk about?
I think the point that I'd really like to hammer home is that we as psychiatrists are very much privileged to have longer appointments and more time to talk to our patients about their sexual health and well-being. And so we should all be equipped to know what to do next if we think our patients are good candidates for pre-exposure or post-exposure prophylaxis. So I think the only homework I would give on your podcast is to familiarize yourself with what that next step looks like, so that if you have someone in your office and you think they meet that criteria, you know where to refer them, and you're not asking all these questions about your system and how your system works in the moment.
I think a lot of times we're the first people that patients are open with in a lot of ways. We get the privilege of hearing people's secrets, and then they may have been, revealed things to us that they haven't revealed to their other physicians.
Mm-hmm. Absolutely. And I think as far as secrets and stigma and access to care, if for one reason or another you don't want to have your pill bottles at home with your PrEP, an injection every 2 months is quite discreet in comparison.
Yeah, absolutely. And you don't have to remember.
Exactly.
All you have to remember is an appointment.
Exactly. I'd love to know more in the future about adherence rates to psychiatric medications in general. I think there were a few comments during the grand rounds on this topic about how we encourage our patients to take their medications. And there were some practical advice, so having a pill calendar or even setting out 2 weeks worth of medications so that you know when it's time for a refill. But I just don't know, like I haven't reviewed the evidence that explained like this is what works with adherence and this is what doesn't work. I think I had made a joke during the presentation about fear factor and kind of
right?
Scaring your patients into adherence, but I bet there are studies out there that says that doesn't work.
Yeah, maybe not. Yeah, probably. Well, fear factor for other things like, smoking, like you smoke, the fear of getting cancer, the fear of COPD or something doesn't really tend to motivate smokers to quit smoking, at least in that case. One of the things that I do, which I don't know, but I imagine probably increases adherence to taking the medications every day, as I talk about withdrawal symptoms with patients. Like if you stop taking this medication suddenly or you miss a few days, you might experience these things. And at least for my more nervous patients, they're probably far less likely to miss a dose just because they're a little bit concerned about the withdrawal.
I will say that in the health system that I work in, there are some pretty strict guidelines with the frequency of appointments to get PrEP, especially in the beginning. You're seen day one, and then you're seen a month later, and you only get 1 month of medications. And I think they kind of limit the supply of the medications that you get because people are so concerned about getting HIV that it encourages adherence to the testing that are required. I'm sure that there is good evidence to support limiting the supply of medications to link that to the necessary lab testing, but I haven't seen the studies myself.
So what you're saying is that in order to get more medication, someone has to come in and actually get the labs that they need to confirm that they're still HIV negative.
Exactly.
So in some ways, it could be seen as a barrier because they have to come in more frequently. But at the same time, it's also part of the treatment. You need to know if you are HIV positive or not, because the medications that you use for PrEP are not appropriate for someone who is HIV positive.
That's right. And I think that raises the question of access to PrEP, and are you doing more harm than good by creating these barriers? Or is it better in the long run to have these wickets so that people get the medications that they need if they do convert to having HIV?
And also prevent potentially having more resistant HIV strains if you're treating them with the PrEP medications instead of the more appropriate regimens that they give you once that they know you've been infected with HIV. Thank you, Jan, for coming on. It has been a pleasure.
Yeah, the opportunity to listen to myself speak is not one that I'm excited about.
You don't have to.
Yeah.
I mean, I could just drop it.
Just no, well, thank you so much for thinking of me for this project. I hope that we learned a little bit about HIV prevention, so I appreciate it.
Yeah, and anytime you find yourself excited about any other topic and you want to come back, just let me know.
Okay, you'll regret that offer, I'm sure.
Potentially.
Okay.
All right, thanks, Jan.
All right, thank you.